Okay, good morning. So I'm Dr. Greenaway Williams. I'm a pediatric gastroenterologist and hepatologist. And this morning's lecture is on chronic abdominal pain, which is a huge topic. And so we're going to focus a bit on the approach to evaluation of a child who presents with long-standing abdominal pain. All right. So a child who chronically complains of pain is a very common scenario in pediatric general practice. And these patients often pose a formidable challenge to caregivers, to their parents, and to healthcare providers as well. The child, him or herself, is often in distress, and the parents are often extremely worried and probably also frustrated because they've been to, 2 or 3 other doctors, and so far nobody is able to come up with a problem. And then we as healthcare providers worry about missing serious occult disease. And so oftentimes, to make ourselves feel better, we tend to overorder investigations. And in many of these cases are wrapped up in psychosocial complexities that make it difficult to tease out exactly what's going on, and also pose a significant challenge to management. This is something that you are going to see, if at all you do see children in your practice, and so you need to have an idea of what is a reasonable approach and a balanced approach in terms of making sure you don't miss something, but also not over investigating and making the problem worse by feeding patients and parents anxieties. So we're going to look, in terms of the outline for today's lecture, we're going to look at just review some of the terminology around chronic abdominal pain. I will touch very, very briefly on the pathophysiology and some of the key questions in the history and signs to look for on physical examination, so that you don't miss, occult disease, and red flags that should prompt further investigations and or referral to a specialist. All right. Okay. All right, so you may see the term recurrent abdominal pain floating around. We do not use that terminology anymore. Rather, we use chronic abdominal pain. So chronic abdominal pain is abdominal pain that is long-lasting. So it's present for at least 2 months. It doesn't have to be constant, though. It can be intermittent over that 2-month period at least. And then under this umbrella of chronic abdominal pain, you have a minority, so a small minority of patients who have underlying organic disease. So, and there's a long, long list of organic diseases that might cause chronic abdominal pain. But a much, much larger proportion of patients who complain of abdominal pain have what we call functional abdominal pain disorders. Okay, so functional abdominal pain is abdominal pain without a demonstrable evidence of some pathological condition, right? So no matter what investigations you do, what you've asked on history exam, you're not able to identify any anatomic, metabolic, infectious, inflammatory, or neoplastic disorder to explain the child's pain. And these functional abdominal pain disorders are classified into 4 main groups. So functional dyspepsia. So those patients tend to have more upper GI symptoms, burning, epigastric pain or tenderness, bloating, nausea, vomiting, that kind of thing. And then irritable bowel syndrome, which I'm sure you've heard of. Patients tend to have more lower GI symptoms, alternating constipation or diarrhea. abdominal migraine, which is actually not very common, and so it shouldn't be the first thing on your list, on your differential when you're thinking about kids with functional abdominal pain. And then we have all those other kids that fit in, we lump into this group of functional abdominal pain not otherwise specified. So basically they don't meet the strict criteria for functional dyspepsia, IBS, or abdominal migraine. And then I have in brackets here functional constipation, and as a strict part of the definition, functional constipation is not classified as one of the functional abdominal pain syndromes or disorders, but it is very common in pediatrics and can cause chronic abdominal pain. That too is basically constipation without an demonstrable evidence of any pathologic condition. So that's why it's also termed functional constipation. All right, and functional abdominal pain, as I said, is common with a pooled global average of about 14%. So this is something that we really do see quite frequently. All right, so for this lecture, I'm not going to go into the details of the diagnostic criteria for functional dyspepsia, IBS, or abdominal migraine. I think you guys can look that up if you're interested. But I think what's more important for you is to understand how to approach patients with chronic abdominal pain. So understanding that most patients will actually end up having a functional abdominal pain disorder, but remember that there definitely is a group of patients who will have underlying organic disease, and you don't want to miss that. All right, so just one slide on the pathophysiology here. And my disclaimer here is that this is very much an oversimplification, and there really remains a lot that we don't understand about the underlying pathophysiology of functional GI disorders in general. Overall, though, the pathophysiology of functional abdominal pain is thought to involve changes in the way pain is processed, with visceral hypersensitivity or hyperalgesia ultimately leading to pain and disability. So we know that several factors contribute to this. So these may include medical events early in life, such as an enteric infection. So you get a viral gastroenteritis, for example, and that kind of sets off this cascade of changes in the way that your, the gut-brain axis processes pain, and that becomes a long-term issue. The other things such as sensitizing psychosocial events, social stressors like bullying or family discord, loss of loss in the family, or some maladaptive coping style. So we know very much that the gut and the brain are very closely connected, and that underlying anxiety or emotional distress can definitely manifest as GI symptoms, and we believe that this plays a major role in functional GI disorders and GI pain. A lot of this is often superimposed on a background of genetic predisposition. So there's often a family history of functional GI disorders. If you really, perhaps the patient doesn't come to you with the diagnosis of IBS or functional dyspepsia, but when you talk to mommy and daddy, you realize that they might be having similar symptoms, or the grandparents may be having similar symptoms. So there's often a significant family history. I think understanding a bit of the pathophysiology helps you to realize that there are certain key things you have to focus on in the history. So the psychosocial situation, you really do have to delve into in your history. What is the what are the home circumstances? What are the school circumstances? How is the child have there been any disruptions in the family environment or at school that could be contributing to this? You definitely want to ask about family history. As I said, I think these disorders tend to run in families. And then you want to ask about medical events early in life, which could be, some of those sensitizing factors that kind of set off the whole cascade. So, whether they had infections or there seems to be some kind of underlying motility disorder, that kind of thing. So I would recommend about a 3-step approach to evaluation. You first want to identify red flags or alarm findings, and we pick those up almost entirely on history and examination, and then we complement our history and examination with a few screening investigations. So it's really not necessary to do a whole wide range of investigations in every patient that presents with chronic abdominal pain. A detailed history can help you to figure out whether or not this is organic disease or is this functional disease, and save you and save the parents and the child a lot of distress and money in terms of going down the road of multiple investigations, some of which are invasive, so you have to be very selective of who you're going to choose to do a colonoscopy on, for example. Then you want to identify contributing factors, and so these may include biopsychosocial factors that can trigger or reinforce pain. And it's important to understand those contributing factors if you're going to have any success at managing functional pain. So, understanding the family dynamics, understanding how parents react to the child's pain. Do they encourage the child to play that sick role because there's some underlying benefit that the child gets from being quote unquote ill, or are they using appropriate distraction techniques and trying to help the child to cope and push through? And so, all of this will help you to decide how you're going to outline a comprehensive and holistic management plan for this family. And then thirdly, it's really important to establish a therapeutic alliance very early in the course of management. So as a doctor, you want to reassure the child and their family that you're taking the complaints seriously. So it is not all in the child's head. The pain is real, but the pain is real, and you want to allow them the freedom and the time to express their concerns. So it's not the kind of, when a child comes to you with chronic abdominal pain, it's not a quick 10-minute history that you're going to take. You need to try to build rapport with the family. You want to make sure that you allow them to vent and to explain to you everything that's happening. This allows, I think, them to build trust in you. If you listen to them, you're going to get a lot of information, and you prove to them that you want to hear what they have to say and you believe what they have to say. And then I say very early on, so even before you've done a whole barrage of investigations, before you know for sure that this is not organic disease, you want to introduce the whole concept of functional GI disorders. A lot of people don't know about functional GI disorders. They feel that if they have abdominal pain, something must be physically wrong with some organ in their abdomen. And if you can't find what's wrong, then that means you're just not a good doctor. But I think very early on, so before you've done all the investigations, you need to say, you need to explain, there is this large group of disorders that many people do suffer from that cause significant pain and disability. And, we're going to make sure that we look for any physical disease in in the abdomen, but at the same time, we're going to also have an open mind that perhaps this also could be functional. And I think it means that after, if you've said it from day one, after the fourth and fifth visit, with reevaluation and tests and so on, and you come up with nothing, it doesn't look like all of a sudden you've made up this diagnosis of functional pain because you couldn't find something physical or organic to pin the pain on. So you want to be very upfront about what functional GI disorders are, that they're an important cause of abdominal pain, and that we have to explore that as one of the possible differentials, in addition to the several organic causes that are there, but the organic causes by far are much less common. All right. So if you go home this evening and you look up, what these functional abdominal pain disorders are, and you look up the Rome criteria, so you'll find it's a few bullet points for each of the disorders, the functional dyspepsia, IBS, and abdominal migraine. You can look up the Rome criteria for diagnosis. You'll see that for functional abdominal pain not otherwise specified, one of the diagnostic criteria is that you've done appropriate evaluation and the abdominal pain can't be fully explained by another medical condition. So we all have this fear that we're missing some real organic disease for a few reasons. One, it's more tangible. It's something that we and the family can see and that we're trained to do something about, okay? Conversely, most of us, even at the subspecialty levels, even at my level, we are very poorly trained, if at all, on how to manage functional disorders. So we're afraid of them. It's like it's easier to diagnose a kid and treat him for inflammatory bowel disease than it is for IBS. Somehow there's a kind of block, a mental block that we as physicians have sometimes. And then society and the medical community have this inherent bias against these mind-brain disturbances. And it sounds a little hairy-fairy and doesn't, feel like a real diagnosis. But functional pain is real, and we really need to be open to recognizing it, and we need to become comfortable treating it, or at least be able to recognize it and refer patients on to someone who is comfortable treating it. Okay, identifying it in most cases, as I said, can be done with a very good thorough history and physical exam. There's usually very little indication for extensive investigations. So point 3 here, where it says after appropriate evaluation, it says appropriate, not extensive, because you really rarely need extensive investigations to come to a diagnosis of a functional abdominal pain disorder. But before diagnosing functional abdominal pain, you do have to reassure yourselves and the family that we're not missing organic disease. So there really are a few things that you need to think about and explore in your history and your examination. And then a few key screening investigations. Okay, so as I said, the history is really, really important. I think this is what is really going to inform your approach to evaluation and management. And as I can't say it often enough, the diagnosis is usually in the history. So just let the patients talk, let the parents talk, and also let the child talk. I think it's really important in pediatrics to remember that the parents don't know everything. And the children, if you listen to them, they will tell you also what's happening, even the little ones. All right, so don't ignore them in the room. Involve them in the history-taking process. Try to develop a rapport with them and let them explain to you how they're feeling and what's happening. Key things you want to ask though, you want to find out about the duration of the episode. So, bouts of pain that last a very short period of time are unlikely to be worrisome, even if it occurs, 20 times a day. If it's, sudden onset, lasts just a couple of minutes, goes away completely on its own, it's probably not worrisome. We know that constant pain, that is unrelated to, constant pain is likely to be unrelated to physiologic events like eating or defecation. And so constant pain too is more likely to reflect pain of a central or a CNS origin for pain. Okay, pain that's worse with eating suggests that the cause is stretching of the stomach, so the dyspeptic type symptoms, or they could have this gastrocolic response, which increases pressures in the colon, and they interpret that as painful. If defecation relieves pain, this is really classic for IBS. So they have pain right up until they need to use the bathroom. They go and do a number 2, and then they feel much better. That's pretty classic for IBS. And then if eating and defecation have no effect, but exercise makes the pain worse, then the diagnosis could be related to the abdominal wall and unrelated to gastrointestinal factors. So it could be musculoskeletal in origin. So the duration of the episode, but also the timing of complaints and how it relates to the physiological things that we do, so eating, defecation, can give you an idea of whether or not this pain is organic or functional. And then, of course, a thorough psychosocial history is of paramount importance. You want to make sure that this child is not, is there marital discord at home? Is the child being emotionally abused at home? Is there a child being bullied at school? So that kind of thing. The timing of complaints. So do you think, so is it that the pain, they don't have the pain on weekends, but they have the pain on weekdays, or they don't have pain over the summer holidays, but they have the pain during school time, and gives you a little red flag that maybe something's happening at school that they're trying to avoid. So all of those questions you have to make sure you delve into in detail in the history. And then we talk about red flags, but I think first I like to talk about green flags. And these are the things in the history that point to pain that's more than likely functional. So persistent pain that doesn't change no matter what you're doing. So no matter, you eat, the pain is still there. You go to the bathroom, the pain is still there. So that kind of pain too, the pain that's just constant and doesn't vary, it's not usually related to organic disease. The presence of several other somatic symptoms. So, and a lot of times those somatic symptoms don't add up. Then you have to wonder in the back of your mind, is this functional? The child that tells you that absolutely nothing works. They've tried every medication. They have side effects, and that's why they can't use this medication or that medication. No matter what they do, nothing helps. The coexistence of an internalizing disorder. So these, patients who are anxious, your type A patients who really internalize everything and overanalyze and think about everything. Certainly, if there's a family history of functional GI disorders, specifically IBS. And then you have the parents that often feed the functional pain, and these parents tend to be the ones that are anxious, and everything seems like a big deal, and they're worried, or overly worried about everything. And as I said, you look for potential stressors like parental divorce, hospitalization, bullying, abuse. If those are in the picture as well, there may be a functional element to the pain. You want to make sure that you assess coping strategies and resiliency. So how does the child or adolescent, or how does the parent cope with the pain, and generally how do they cope with stress, and whether or not they cope in a healthy way or not. Sometimes those who have unhealthy coping strategies are more likely to have functional issues. Does anybody have any questions about any of that? So you really do have to explore in your history all the organic stuff, right? And I'm not going to list all the features of inflammatory bowel disease and all the features of peptic ulcer disease and all the features of pancreatitis, chronic pancreatitis. But these are all, think of all the organs that you have in your abdomen, and you really have to go through methodically in your history and ask about symptoms that could be related to each of those. But then you also, in addition, have to explore the functional side of things. And if you're getting, no to all the IBD questions, to all the peptic ulcer questions, to all the chronic pancreatitis questions, and so on, that the rest of your history is fleshed out with the whole psychosocial side of things, the family history, and so on. And that's how you reassure yourself that, well, we've explored all these organic issues in history. There seems to be some supporting evidence that there's a good setup for functional disorders in this child and this family, and therefore I'm more likely to lean on that diagnosis as opposed to this being inflammatory bowel disease or chronic pancreatitis, for example, okay? Oh gosh, I realized I was talking about green flags out of my head. Okay, we said all of these things. Yeah, this is pretty much what I just said. So the next slide is about red flags. So in history, you want to make sure definitely that there are no red flags. Some of the ones that I would want you to look out for specifically would be a family history of inflammatory bowel disease, celiac disease, peptic ulcer disease. You want to find out, is the pain, in terms of location of the pain, is it persistent right upper or right lower quadrant pain? And that can be ominous. You want to ask about dysphagia and adynophagia, so that's difficulty swallowing and painful swallowing. If there's a history of persistent vomiting, and certainly early morning vomiting or nocturnal vomiting, that's very unusual. If there's any history of GI blood loss, so vomit that contains blood or coffee grounds, or stools that are bloody stools or black tarry stools, that's also ominous. A history of nocturnal diarrhea, so pain, basically waking up because you feel the urge to pass stool, and that is most often pathologic. If there's an associated history of arthritis, so not arthralgia, a lot of patients may complain of joint pain, but actual arthritis is often associated with inflammatory bowel disease, for example. Perirectal disease, so fissures, tags, abscesses, all of that is a red flag for organic disease and inflammatory bowel disease. If the patient is losing weight unintentionally, that's also a red flag. So you must look at weight loss. You must ask about height. So is this a child who started out being of average height in their class and now they're the shortest one in their class? Is there some slowing down of their linear growth? And it's very, very important in pediatrics to try as best you can to get objective markers of growth. So if you have a series of weights over time and a series of heights over time, to plot those on an appropriate growth chart and look at the pattern of growth. Is it normal or are they falling off? And if they're falling off, that's a significant red flag. Delays in puberty, you'll get with constitutional disease, and so you want to ask about that as well and check for the features of puberty on examination. And certainly if there's unexplained fever, that is also worrisome. So you want to definitely explore in the history these key red flags And as if you identify any of them, they will point you down a specific road in terms of further investigations. You have to use your clinical judgment and try to put together what might be considered, a single alarm finding in the whole context of the history and physical examination. So one red flag doesn't mean a diagnosis of inflammatory bowel disease, but it must raise your suspicions, and you want to look very carefully at that red flag in the context of everything else and see, do I need to go a little bit further in terms of investigations? But you're really not going to know what investigations to do, because there are lots of investigations you could do for chronic abdominal pain unless you really get lots of detail in the history and be guided by that. So just a point that if you have bloody stools plus anemia plus a history of weight loss, that's a really strong predictive value, really strong predictive constellation of symptoms and signs for inflammatory bowel disease. And you'll see that doing a CBC is part of, one of the routine screening investigations that we'd recommend. All right. All right, so just to go over a typical case of, what you might get, some of what you might get in the history. So, and I've seen many cases like this. So a 15-year-old girl, she complains of periumbilical pain every day since puberty. So for, years now. She says the pain is constant, but it's worse after ingestion of greasy foods and pizza. She's tried everything, but nothing has helped. There are no other medical problems. She's homeschooled even before COVID. She's a high achiever, gets grades in the 90s. The pain does prevent her from participating in sports. She's an only child. Her parents were separated a couple of years back. Mommy has IBS, and you think based on your interaction with this child that she has some features of depression or low mood. And then on your observation as an exam, you realize that she's reporting severe pain even right now in the office, but she does not show any outward sign of painful distress. So she's not rolling around in pain. She's not crying. She is exasperated because she feels that nobody believes her, and every answer to your question is sometimes or maybe. She's also overweight. She has generalized tenderness on palpation, but no rebound or guarding. You just see appreciate a small amount of stool on the diary. It's soft and there's no blood. And so basically, she has an essentially normal examination, and her tenderness is distractible. So in a kid like this, how much testing does she really need? And if we're honest with ourselves, in most cases, the extent of the workup is driven not because of the fact that we think that something is seriously wrong, but by the degree of parental anxiety or our own insecurities. So why do we test? We want to test because we want to make sure that we make the correct diagnosis, of course. We want to reassure the family and ourselves, and we want to reassure the patient and the family, but we also want to reassure ourselves. And we have to try not to go too overboard with that. So these are the screening tests that I tend to recommend off the bat. So a Cbcr differential, and you want to look very specifically for anemia. You want to look at an eosinophilia that might indicate some allergic GI disorder, which could present with chronic pain. We recommend doing inflammatory markers, so an ESR and CRP. And I like to do both because some people who have inflammatory bowel disease don't mount a CRP response, but they may have an elevated ESR, for example. We recommend screening for celiac disease. And celiac disease, it's the whole global prevalence is changing. It's not classically thought to be common in African American or Afro-Caribbean populations, but I think it's one of those silent diseases that sometimes we miss because we're actually just not looking for it, and it is a culprit in many studies of chronic abdominal pain. I usually a basic biochemical profile, so looking at your renal function, looking at albumin, protein levels, and liver function tests to see whether or not we think this is hepatic disease or something nutritional. And then stool tests, we can test. So if the stool overtly has blood in it, then you don't need to send them for fecal occult blood. Fecal occult blood is looking for blood in stool that's occult, that you cannot see. We usually do stool cultures, so for overcysts and parasites as well as stool cultures, fecal leukocytes, and stool tests for H. pylori antigen. You could consider doing. The gold standard for diagnosing H. pylori gastritis is endoscopy, but truthfully, even patients who have H. pylori gastritis, that doesn't tend to be, even once you've treated it, it doesn't tend to be the underlying reason for their chronic pain unless they actually had an associated ulcer. That's what we've noted in children. So if you ended up doing an H. pylori antigen test in stool and it came back positive and you decided to send them to the gastroenterologist for endoscopy, we found H. pylori and we treat it, we wouldn't necessarily expect their chronic pain to disappear. So I don't think that that is, the answer necessarily. Right, so that's for H. pylori. And then fecal calprotectin is a marker of inflammation in the colon and the intestines. And that is, if your fecal calprotectin is dead normal or low, then it's unlikely that there's inflammation within the intestines. But a lot of times the fecal calprotectin comes back in a gray area or elevated, and you do have to go on to consider whether or not this child needs endoscopy or not. Right, so those are the tests that I would recommend. Of course, negative screening tests are reassuring. So if you do all these tests and they come back normal, that's reassuring. But in terms of evidence-based, only 2 tests have been shown to be cost-effective in the absence of red flags in children. So you take your history, you don't get any red flags, but you do your fecal calprotectin or your celiac screening, and that may come back positive even when you had no red flags in the history. So if it's available to you, doing celiac disease serologic testing as a screening tool for celiac, because the definitive diagnosis of celiac is made on endoscopy, and sending off a fecal calprotectin, that might be the way to go, even if you don't have red flags on your history for inflammatory bowel disease or for celiac disease. One more point about H. pylori. So if you ever see an exam question on this or anybody ever asks you, if you're not going to do an endoscopy to confirm diagnosis, the next best thing is to do a stool antigen test. We do not ever send serum or blood and do blood tests for H. pylori, okay? So you should never ever do that. That is always the wrong answer. All right. All right. So, and then it's important to note, if there are no red flags on history and examination, please do not go ahead and order abdominal x-rays to rule out constipation. You want to make that diagnosis of constipation on history and exam. Do not go ahead and order abdominal ultrasounds, esophageal pH studies, upper GI series, HIDA scans, CT scans, and certainly don't refer to me for endoscopy if literally everything comes back normal in your history, your exam, and these screening studies, okay? The more you over-investigate patients is the more you feed their belief that something must be wrong. Because if something wasn't wrong, why is this doctor sending me for test after test after test? He or she must believe something is wrong with me, and so they're going to keep searching until they've found it. And we find that when patients have been through months and months of investigations, they already have in their mind that something must be wrong. And if this does turn out to be functional, it's really, really hard to break down that belief system that they have that something is physically wrong. So you really don't want to over-investigate or prolong the investigations. And just to note that some of these disorders can coexist. So just because someone has a functional pain disorder doesn't mean that they can't actually have organic disease. And actually, we do see many patients who have IBS have a diagnosis of both IBS and celiac disease, for example. Okay. Okay. And regarding the role of endoscopy in screening for inflammatory bowel disease, so this study showed that there's no value in exposing children to endoscopy when your stool calprotectin levels are normal, so under 50. So stool calprotectin is not something we have readily available in Jamaica. It can be sent off by one of the private labs, but it's expensive. But it is a great screening tool that I wish we did have, and I think we'd be able to avoid lots of endoscopies if we had it. Okay, and I did say this already, that studies have shown that there really is no association between H. pylori and GI pain in children unless they have and also associated with it. All right, and then we do have to think outside the box, and then these are the things that your specialists may think of. But there are other things that cause chronic abdominal pain that you may not think of on the usual list of stuff. So biliary dyskinesia, chronic appendicitis, which is actually a thing. So biliary dyskinesia is a validated functional gallbladder disorder in adults. So we don't really have difficult to say exactly how it presents in children, but it requires biliary colic in the diagnosis. Most kids will require, in contrast to in studies in kids, there is upper abdominal pain, no gallstones on ultrasound, but then an abnormal gallbladder if ejection fraction. So it's not an easy diagnosis to make, and it's something that that you could think of and refer to the specialist about. Mentioned chronic appendicitis, chronic abdominal wall pain. So sometimes you need to think about musculoskeletal or nerve pain associated with the abdominal wall, and that could be the culprit as well. And this thing called median arcuate ligament syndrome, which is really rare in children, and you don't really have to know about. All right, so as I mentioned a few times before, delaying the diagnosis of functional GI disorders often leads to unnecessary diagnostic workup and can be very, very costly, as well as distressing for the families and the child. It also increases uncertainty. As I said, the more tests you do, the more you feed the belief that something organic must be wrong. And then the more negative results you get, the more convinced they become that you must be just missing something and you're not thinking of something. And the more you delay by doing test after test after test, is the longer you wait to start treatment. And we know that prompt diagnosis and treatment increases significantly the likelihood of significant improvement or even resolution of symptoms. So those patients that start their treatment early tend to be those that respond better. All right, you always want to remember to refer to a pediatric gastroenterologist if there's one available to you, or a pediatrician in the event of any alarm features, any abnormal test results, including abnormal celiac serology, and H. pylori stool antigen. And certainly, if you have made a good attempt at treatment, so if you think that this is functional and you have made a good attempt at treatment and it's not working, send them along quickly. Don't let them languish in your office. Okay, so the take-home messages for today is that functional abdominal pain disorders are really a common cause of distress for patients and their families. To diagnose them, we can often get the answers on history, and we want to use red flags as well as green flags to tailor investigations, and do not get sidetracked by incidental findings. You always want to look at the whole picture and the whole patient and the whole scenario, and try to make good decisions in terms of how far to go with investigations. And if you feel stuck, ask for help. So there are specialists out there who can help. All right, that's it. Any questions? All right, I spoke a lot today about functional abdominal pain because it's super common. All right, and most of these kids that you'll see with chronic abdominal pain do not have underlying organic disease. But I don't want you to leave thinking that you can't look carefully for organic disease. You have to do that in the history. So don't forget these. This list is important. So don't forget to look for your alarm findings. And then in investigations, this is a good place to start. And I think once you've done this, referring them on to a gastroenterologist early is prudent. Okay. All right. If there are no questions, that's all I have for you today.
Thanks, Doc.
All right. Thank you too. Bye-bye.